And I would like to thank the ESMN for inviting me to tell you something about oncosexology care in the Netherlands. Well, Jacques already said, my name is Ilaniek Zantingh. I'm a clinical health psychologist and a sexologist. I'm working in clinical care, and at this moment only in the Antonie van Leeuwenhoek, which is only for cancer patients. I'll just continue when you... Because in the Netherlands, not only oncosexology care, but all sexology care is rooted in the biopsychosocial model. Joke already said something about that yesterday. And that has implications for both research, education, and clinical care. And I will come to that also later. About our special interest group is also about all factors that are in the biopsychosocial model. It assumes that there's no single factor determinative. And I'd like to point that out. Of course, you all know that, but I want to stress it again. It's not just biology, it's not just psychology, and neither just relationship, society, or the culture you belong to that determine what we want with sex, what we do with it, and what we experience from it. Biological factors, I'll just go through it, but in oncosexology specifically, it's amongst others age, hormones of course play an important role, the type of cancer, but also the type of treatment patients get, medication, like additional medication that's given, and temporary or persistent disability like amputation, scarring, or a stoma. Social factors include, of course, relationships, or a relationship or relationships for the future, type of communication in the relationship, religious beliefs and belonging to a culture or a subculture, the amount of social support people have or get, and the possibilities for social contact. Psychological factors that are important in oncosexological sexual health. They include, amongst others, the positive evaluation of sexual stimuli, motivation, the motivation you have, all the different kinds of motivation you can have for engaging in sexual activity, mood disorders, anxiety, existential anxiety, that's also, of course, plays an important role in cancer, self and body image, we already talked about that, grief, like acceptance, through going through the process, grieving of things that are lost in your life, but also in your sexual life. Possible trauma in the past, or sometimes trauma from the medical care that you receive, and the amount or the psychological flexibility a person has. That's all factors that are determinative for the sexual health and also in oncosexology. In oncosexology health, we have these, this is still in Dutch, but three important pillars, so to speak, where all these biopsychosocial factors also play a role. So you have sexual function that is determined by these different factors. You have the sexual self-image, sometimes referred to as sexual identity, but then it gets kind of confused with sexual identity we use in society as a whole. So I'd like to call it sexual self-image. And of course the sexual relationship. All of these three pillars are influenced by these biopsychosocial factors. Then oncosexological care. Bruno already also said, had a nice and a beautiful overview of that. In the Netherlands, basic and specialized oncosexology care that patients receive, partly also in the Netherlands, although that's being seen as top of the bill, but also with us, it depends on which hospital you go to, which healthcare professional you encounter, and the amount of ease or training they have received in sexual health. As a consequence, sexual problems are often only addressed by the patient themselves. And whereas we know from research that many patients are hesitant to address this topic, even if they want or they would like help with it. So there is still a big field for us as healthcare professional up there. Fortunately, we see that healthcare professionals increasingly use, for example, patient routine outcome measurements. And in Holland, we have the lastmeter. It's like a measurement of distress, which to get a better idea of what the patient needs for care, like in psychosocial or physical therapy area. And the lastmeter contains one question about sexual problems, so it's a start, and from there they can continue. And if a patient gets referred for more oncosexological care, it depends on what the hospital has to offer. And it can either include a referral to an urologist, gynecologist, endocrinologist, or a specialized nurse that have training in sexology care. It can be a pelvic floor physical therapist, or trained medical social workers or medical psychologists. Some hospitals have certified sexologists employed, and there are a number, of course, of centers for sexual health in university medical centers that, of course, they do the whole range of sexual health and with medical problems. And they, of course, also offer care for oncological patients. Unfortunately, you had probably all had received the mail a couple of weeks ago, like 1.5 weeks ago, one of the most important centers in the Netherlands, also for oncosexological care, like, I don't know if you did, like the SPARK study, at Leiden University is presently threatened in its existence. It's a little bit small on the screen, but if you see in your mail, you can go to the petition, so please sign it so we can all support them and hopefully prevent it from being closed down, because that would be a step back. An important part of basic oncology care is giving the patient information on the possible effects of cancer and its treatment on sexual health. So that's what we call, or I would call, the basic oncosexological health, not done by sexologists or other trained, but basically by all healthcare providers, healthcare professionals. Asking about possible sexual problems the patient might encounter during treatment is also part of giving permission to talk about the subject, permission that the patient might encounter problems. So if you ask for it, then that's like the first stage of the PLICIT model. Maybe some people know the PLICIT model is also pretty widely known. Afterwards, the healthcare professional needs to routinely check on the problems and on how the patient is doing in this area, and also assess if more specialized help is needed. Training in talking about sexual problems needs to be a part of this basic education of both oncology nurses, but also regular nurses, because there's also, besides cancer, a lot of other medical conditions that, of course, affect sexual health. And physicians, not only nurses, but also the physicians, and also oncology physicians. Up until now, training is in oncosexology rather scattered. For example, nurses who give like the penile injection instruction, they get their instruction, they get their training by the urologist. The urologist refers to them and they do that part, or they get the training from the colleagues, or the one that did it before them. Like the Spark study, I already mentioned that. It's a study for sexual rehabilitation for women after radiotherapy. The nurses that are in that study, they are trained to impose or use several modules for sexual health, really specifically aimed at this patient group. So there's the training, and of course we hope after the study this will also roll out to all the different hospitals. And some healthcare professionals with affiliation with sexual health will follow a postmaster education or training. And then about education for patients, they get their information through the healthcare provider, but also a lot through, of course, the internet. They will look for information on cancer and sexual health there. There are a lot of websites and podcasts nowadays from both different and joint patient organizations. In Holland, we have the NFK, okay, and oncosexologists that have websites. A couple of examples are Sex and Sex, de bespreekkamer, de herontdekking van haarzelf. It's all in Dutch, of course, but those are good. Oh, that's a whole list. You can't read that, but to see there's a whole lot of information available on the internet. To improve oncosexology care for all oncology patients, we try to join forces in a special interest group of different important stakeholders, like there's all the sexologists that work in these different hospitals, but also the NFK, I just said it, it's the Dutch Federation of Cancer Patient Organizations. We think that's really important to also have the patients themselves talk about what is important, and we can all use, because we need that too. We need patients to say, this is important to us. We started in the summer of 2020, so in the middle of COVID, so we have only met online. But we have been able to start a newsletter to send out to all of our colleagues in oncosexology care that are not in the working group or in the special interest group. We discuss complicated cases with each other, and we'll soon start a work group on testosterone in women in cancer. We have pitched for a delegation of educators to get, the curriculum that the ESMN also developed to get more training and education in the basic educations. We've pitched, let's see, we informed each other of the presentations and what we do in the Netherlands or also internationally. And we will be reviewing online information for patients, because that's such an important source of information for patients for potential points of improvement. And in the course of the SIG, we have contacted several European colleagues to see if we can learn from other initiatives in Europe that they have developed. We also have a mission, but Bruno already said a lot of that, so I'm very glad that all our noses are in the same direction and we don't have totally different points or missions or points of views. But yes, improving this basic oncosexology care by the oncology nurses and physician, by making sure sexology is an integral part of the education of healthcare professionals, once again, by training special oncology teams for breast cancer or all the different kinds of oncology teams we have in the hospital, and probably the specialized hospitals all over Europe also have that. For example, by the pink elephant that's developed for breast cancer patients, but especially for the teams to what do we want with this subject, sexual health? What do we need if we want to give a good care in this field? And like, for example, then the team itself will come up with, we need training, we need this, or we need more information leaflets, or so it will come from the team and not from us as sexologists. Let's see. Of course, the research, better implementing the research that is already there and all these beautiful, like the KISS study and the SPARK that's being done, but also making sure it gets into the clinical care. Also improving the research questions and studies that are more closely informed by the clinical care. Improving European collaboration, so that's why I'm here. And developing the expertise centers for sexual health in oncology, Bruno already mentioned that. And maybe organizing an oncosexology conference following a French example that they do like every year for all healthcare workers in oncology. So not for us as colleagues, but for about everything that's going on in oncosexology. Well, my take-home message is short. Let's connect. And well, Bruno already had a beautiful invitation standing. So. We'll see you there, and well, that was it. Thank you.